So I went to medical school at Albany Medical College in 2007, graduated 2011. I decided to go into medicine in the first place, down the typical pathway of a lot of folks who just have an interest in science to begin. But as I continued in my education, both secondary and in college, just started to really take a keen interest in older adults and what older adults and families face as they approach aging, and what that means for the individual, what that means for the family. And there's, as you all know and may be experiencing, a wide spectrum of experience there. And in medical school, I had the opportunity to be taken under the wing of a geriatrician who does all of his practice through home care. And I think that that's absolutely amazing. It was not something that I could picture myself doing full time, but I could picture myself as being a geriatrician and taking care of people across the entire spectrum of care, from home to hospital to skilled nursing and so forth. I should also add in that I was Jesuit educated in high school and in college, and the Jesuits particularly try to teach you to approach your education with a sense of purpose and service. And this is just where I found my strengths and where I found that I could probably do the most good. So I continued on that path, and I've been very happy with it. So since graduating from medical school, I did my residency at Mount Auburn Hospital, chose that hospital because it was a mid-sized community place, as opposed to the Ivory Towers downtown Boston, which I'm glad that we have, and that they're great for research, they're great for tertiary care, but for everyday bread and butter, primary care, geriatrics especially, with the population that we see at Mount Auburn, that's where I see the most value, where people have easy access to their physicians, and physicians who know each other, as far as these subspecialists who might be involved in somebody's care can reach each other, know each other's strengths and interests, and are able to render very effective care that way to each individual patient with their individualized needs. So I was happy to be at Mount Auburn for residency, was a chief resident there right after my residency, went to MGH for 1 year for geriatrics fellowship, where I got to experience a lot of in-depth inpatient, outpatient, as well as rehabilitation and long-term care, and then was able to happily return to my home institution of Mount Auburn to join the geriatrics practice there. And currently I spend some time at Mount Auburn, but also a lot of time at a retirement community in Lincoln, Massachusetts, where they also truly have the spectrum of care, from independent living to skilled nursing and assisted living and memory care in between. So it's really been a seat down in exactly where I wanted to find myself. So that's a little bit more than a thumbnail, but hopefully not exhausting.
No, that's great. And I think, I'd love for you to elaborate a little bit on the model at the Commons in Lincoln, because it is unique. The CCRC type setup is something that's, it's newer to me. I know it's probably a little bit newer to Massachusetts, but talk a little bit about that and your role and just what it is for our audience, and then, your role in that sort of healthcare setup.
Yeah, well, the role itself has changed a lot over the past year and a half in particular, but the basic premise being that somebody will come into a retirement community, continuing care retirement community, either first at the independent living level or at the assisted living level, and then with the opportunity to progress through the community as his or her care needs increase. So if somebody comes in at the independent living level and then may unfortunately experience medical events, functional declines that require them to have more care. They might start by bringing in some additional help by way of home health aides, in addition to intermittent home health services like physical therapy and skilled nursing. But as people might continue to progress and decline, they may find themselves needing more care than can be reliably rendered in the independent living environment, despite bringing in outside care. So then they can move over to the assisted living part on the same campus. And the idea, of course, is that you don't leave the campus ever, regardless of what your needs are across the spectrum of care. So into assisted living, where there are nurses on site all of the time and able to help to assess and reassess and formulate care plans that will keep people happy, healthy, and safe. And if memory becomes a severe issue, then a memory care unit with people who have the skills to often non-pharmacologically, which is important, deal with health and behavioral issues that come up when people find themselves in those unfortunate circumstances where memory is inhibiting their ability to live on their own more independently. And then skilled nursing being the most intensive care environment on this type of campus. We mostly focus on rehabilitation and then discharge back to independent or assisted living, but in some cases, such intensive nursing and custodial care is needed that we keep people in the skilled nursing environment long-term in order to meet their care needs.
Yeah. So, and it's, it seems to be like a seamless transition too. So if you're in an independent care, you can kind of get the skilled nursing care that you need. There's always an open bed, right?
Right. And it's not always a linear progression. I would say most often it's not a linear progression. So somebody might need to go to the hospital acutely, come back to skilled nursing, and then get discharged back to independent living. Or if they're not quite at the point where they need the hospital, some communities like this one, where I am, have the option to be transitioned directly over to skilled nursing, which is not always an option if somebody is in a community by themselves. And by community, I mean in an independent home, like out in Lincoln, out in Sudbury. And they find themselves in a position where they perhaps have experienced a functional decline and injury. And we can oftentimes avoid a hospitalization by being able to bring that individual right over to skilled nursing on a waiver or within a different financial situation that's been worked out when they signed onto the being in the community, such that they don't need to worry about Medicare covering a skilled nursing stay just because they haven't gone to the hospital first, which might not be necessary.
And I think so. It's interesting you say that, the Medicare, the insurance stuff starts to get really complicated. And, that's probably a topic for a whole nother conversation.
Absolutely. That's why I tried to steer away from it immediately, but it was necessary in order to really describe that piece of it.
Yeah. So, in order to access and just, really from a 30,000 foot view, in order to access for most people with a Medicare benefit, a skilled nursing stay. And skilled nursing is typically intensive, an hour of PT, an hour of OT, and whether or not you need it, an hour of speech or 30 minutes per day, up to 7 days a week. Depending on what the need is, you have to have a 3-day hospital admission in order to qualify for that. And that might have changed. I don't know. This seems like the rules are always changing, but
yeah, and they've changed a little bit. Some insurance plans allow for what's called a 3-day waiver, such that if somebody finds themselves in the emergency department or admitted to the hospital floor for only 1 or 2 days, but they're really medically appropriate for discharge and would just be waiting on the floor for no other reason other than to meet the Medicare standard of 3 overnights in order to be eligible to be covered for skilled nursing, then that insurance plan will work with the case manager and grant them this waiver in order to go to skilled nursing early when it's actually appropriate, instead of just being exposed to the hospital environment and infections and things that we don't want.
Yeah, which, it's just, it's incredible how complicated the system can get. But just to summarize what Dr. Rob is talking about. So there's many different settings of care for, as we get older. And in the community that Dr. Rob practices in, there's an independent living section, which really means there's no help at all. So that's just like you might be living in your house. It's independent living. There's assisted living, which is just one level up, which basically it's for folks, and correct me if I'm wrong, Rob, that need just a little bit extra, right? So, difficulty maybe with transfers or, performing their everyday activities, ADLs. But it's very, it's not fully independent, but it's not very hands-on, right?
Medication administration can be worked into the package as well. So functional, yes, that's usually first and foremost in terms of that, what's revolving around that decision. But often with functional does come cognitive disability, and it might not be at the point where somebody needs to be in a memory unit, but at the same time might not be safe to self-administer medications, either for a cognitive or from a functional perspective, not able to handle the pills. So, that's a type of environment where medications can be handled safely by nursing staff.
That's great. And I would love to maybe dive in a little later about some cognitive exercises or some activities that folks can do to hopefully maybe ward off, that trip toward
Absolutely.
the memory unit, because there are things that can be done. We're going to get into that in a little bit. So we've got, that layer. So we talked about independent assisted memory care, assisted living. And then we've got our skilled nursing, which is sort of, the most acute in the setting that you're in, but not as acute as an acute care setting for rehab. So let's say you got in a motorcycle accident or you fell down a set of stairs, you might spend a little bit of time in the hospital at, a Mount Auburn or an MGH. And then you'd get transferred to a Spalding inpatient rehab, which is 3 hours of intense rehab every single day. You have to qualify for that. And then typically from that setting, you may go home or you may go to a skilled nursing facility. But it's just, these are all the things on the call today, why what we're hoping to prevent, down, these decision trees. And hopefully we can avoid some of these with some of our education today. But let's just dive right in. So let's just go over geriatrician. What are some of the most common conditions that you treat, Rob?
I would say orthopedics is a big one. Let me break it down by body systems, and I'm not going to list every single body system. I'll list the most common ones. So orthopedic, cardiovascular, neurologic, gastrointestinal, and cognitive, which kind of falls under neurologic as well. As I said, going down the list, cardiovascular, oftentimes people with lifelong accumulation of cholesterol in the arteries, leading to maybe a heart attack or maybe just decline in heart function, leading to congestive heart failure, at which point, when somebody is diagnosed with either heart attack or heart failure, you're on at least 5 new medications from the point of that diagnosis chronically for the rest of your life. So that's a big complication. Orthopedic, I think we'll take a deeper dive into that today because of the nature of the conversation. But a lot of fractures, particularly hip fractures secondary to falls, a lot of injuries from either falls or just trying to perform activities of daily living, repetitive activities sometimes that results in an injury. Neurologic strokes and Parkinson's disease, dementia, gastrointestinal constipation becomes a big issue for a lot of people as they get to be octogenarians, nonagenarians, centenarians. And I also I want to tack this on sleep disturbance, plus or minus any other underlying depression or anxiety is something that I see very frequently as well.
Sleep disturbance is an interesting one. I know many people, and maybe combining restless leg syndrome in there too. And, I think that's a really, if you have any tips for that, I'd love to get into that in a little bit. But, of all of those conditions, and obviously my brain goes to orthopedic, but
Or,
which ones do you feel as though are the most easily preventable and
mhm,
modifiable?
um, I would like to scoop those both under one umbrella, but it might be impossible. Easily preventable. In order to truly prevent cardiovascular disease, it takes a lifetime or at least decades of dedication to healthy diet or healthier diet. If somebody's making a lifestyle change, avoidance of toxic habits, good exercise, and we can delve into the definition of what good exercise is, and guidance on that. So I think that that is preventable. It can have the most significant impact, but in terms of ease of implementation and how swiftly something can be modified in order to produce results within a relatively short time frame, you're not going to get that for cardiovascular. But what fortunately, I've seen as I've gone on in my so far decade of experience as a practicing physician, is that the functional deficits that can occur in the setting of either fall or some other underlying medical illness can be modified and supported and improved pretty readily in a lot of cases and pretty quickly. We admit somebody to the rehab setting unable to walk, and 2 weeks later or less, somebody is up on their feet, often with a walker, sometimes able to graduate from a walker to a cane in that short time period, and able to go home or able to go back to assisted living. So for those who really like to see almost instantaneous results from their interventions, that's where the money is. So just getting away from the straight injury and functional impairment because of those. For example, if somebody goes into the hospital with a congestive heart failure exacerbation, they might be so short of breath and unable to get up and do anything that their body deconditions within 3 days. And if they're in the ICU for 3 days and then on the regular medical floor for 4 days, that's at least a week before they get to any rehabilitative institution where they can really start making progress back towards their baseline. And do you get seen by physical therapy in the hospital? Yes, but it's really usually just as a point of assessment rather than intensive intervention. And there are some projects that particularly intensive care doctors are trying to implement, but it's not the standard of care right now by any means, trying to get people rehabilitated before things really take hold and people have a massive episode of deconditioning that's very hard to come back from. So, oftentimes we see people who are incredibly deconditioned and not able to ambulate independently, not because they had a hip fracture, but because they had a congestive heart failure episode where they couldn't breathe, so they couldn't do anything. And they really need to be encouraged and taught how to recondition their bodies, but that can happen more quickly in a lot of circumstances than a lot of people think.
Yeah, that's great. And I think it's interesting you talk about, just the intervention and the prevention piece, right? So, my next question to you is, from an intervention and a prevention piece. So let's say somebody does just a checkup with you at the office, right?
Mhm.
What are
Yep.
you looking for in your medical, observation and inspection to kind of guide you to, like, what are you looking for to then give advice to somebody to be able to prevent a fall or an
Mhm.
acute respiratory or cardiovascular, you
Yeah.
know,
So,
yeah.
so yeah, yeah. So assessment begins for me really in the waiting room. I look for people, how people get up from the chair and walk into the exam room, and what that looks like. Are they able to bounce up without the assistance of their arms in order to rise from the chair, or just reach down and barely push themselves off, or do they dig in with their arms onto the arms of the chair and struggle to push themselves up using their arms and legs, and sometimes more arms than legs, to get up from a seated position. Some people might end up rocking themselves back and forth a couple times to gain momentum in order to stand up, which can be a dangerous situation, one might surmise, in propelling themselves forward and not stopping themselves in time to get up or to achieve a standing position without moving forward into a fall. And so I'll look for how they get up. I'll look for people, how people walk into the office. Is their gait steady? Is it unsteady? Are they using an assistive device like a cane or a walker, and are they using it appropriately and safely? Is that the right device for them? Is the gait wide based? Is it narrow? Are they taking long strides or short strides? And what's the speed of the gait? All of this that happens within 5 to 10 seconds provides a lot of information as far as somebody's functional status and what the risk is in terms of having a fall or just progressing downward towards an inability to ambulate safely and effectively and perform activities of daily living on their own. So that's where the assessment starts. And when somebody is in the office, of course, we're checking the vital signs. We want to make sure that blood pressure is controlled so that they're at lower cardiovascular and cerebrovascular risk, stroke. We want to make sure that somebody's overall conditioning and strength is intact on the musculoskeletal overview. Any aches and pains that might be compromising somebody's functional status and causing people to compensate by using muscle groups in a way that is actually leading long-term to injury. That's something that we absolutely want to pay attention to. Is that right knee that's been acting up causing somebody to favor that right side and ultimately causing them back pain or shoulder pain if they're using their arms to compensate throughout the day as well, leaning on things, leaning on the walker inappropriately, and trying to address everything that's coming up as sequelae of that initial deficit, as well as the initial deficit itself. Can a cortisone injection or a hyaluronic acid injection with an orthopedist help to modify the pain and thereby decrease all of these compensating mechanisms that patients are unwittingly developing and injuring themselves with? So that I hope that starts to give a flavor about how the assessment goes and what I'm looking for.
Yeah, that's great. And I think, that's a great, and for loved ones too, if you're seeing, your mother, your father, your, uncle, your sister, somebody who's starting to get to the point where they can't get it up and out of a chair, that's a big issue. And, I always talk about the single leg stance test, right? So if you can't balance on one foot, for more than 5 seconds, you're at risk for an injurious fall. And typically as we age, our gait starts to get, we call it shuffling gait, but you start to take you shuffle because you want to be in double limb stance. You don't want to be balancing on one foot. And there's a number of reasons for that. But, as a geriatrician, it's excellent that you're looking for that, because that should immediately, result in a referral to PT, for a balance assessment. And I'd love to, let's focus on the 50-year-old, like that active 40 to 60-year-old person who really just wants to prevent turning into that person in the waiting room who's really struggling to get out of the chair, right? So that's what I want this kind of webinar to target. And I want to talk about some of those prevention tips and what you tell your patients and what you wish you could tell your patients. So if you're seeing, on average a 70 plus or a 65 plus population, what you wish you could have told them when they were 40 or 30, where does that conversation begin, Rob?
Yeah. And broadly, I would say, stay active, eat right, avoid toxic habits, and stay socially engaged. But there's a lot underneath each one of those headings. Much easier said than done. And even if somebody is trying to do all of those things right, there are a lot of pitfalls that can occur that might not lead to the outcome that that individual is going for. So just taking each one of those headings a little bit deeper. So staying active, we all know that even just walking at least 4,000 steps per day prevents or decreases the risk of death significantly. And
What does that look like? 4,000 steps? Is it a mile? Is it a half a mile?
So that would be, I would say that's
Kind of got velocity, I
probably,
guess.
yeah, right. Yeah, depends on the stride length and so forth. But some of the more recent studies have kind of centered around that at least 4,000 step mark. That might seem like a lot or a very small amount to some individuals, but at least that indicates a not completely sedentary lifestyle if you're able to reach that, as opposed to the 10,000 steps that a lot of people try to reach, which is not bad, but might seem like a lofty goal for some. So even just starting small, making sure that one is not completely sedentary is a great thing to do. But going back to just the example of walking, yes, that is the first step, no pun intended, that you want to take. Yeah, within 1.5 seconds, pun intended. But yes, you want to remain ambulatory in the first the way to initiate that process is to ambulate. But there are a lot of things that can and should be done in addition to that and around that in order to make exercise, the effort toward exercise actually effective. Just walking every day is good for the cardiovascular system. It's good for balance, but it's not going to necessarily prevent over the next 40 years, you're talking about a 50-year-old, over the next 40 to 50 years of, somebody developing osteoporosis, developing rotator cuff injuries, developing what we refer to as proximal muscle weakness. And that particularly has a bearing when we're talking about what we were before with getting out of a chair, those quad muscles, staying strong enough and healthy enough in order to be able to perform certain movements safely and painlessly. So getting in touch with a physical trainer, if not physical therapist, at least for a 1 or 2 time consultation when you're feeling well, in order to get advice on what exercises one should be doing in order to ultimately protect yourself 30, 40, 50 years down the line from becoming injured and or getting deconditioned is really important. So for individuals, even backing up to your 30s, you should be doing rotator cuff exercises in order to prevent injuries there. After your 40s, making sure to start doing squats safely, and hence the need for guidance around that in order to maintain that function. And certainly above so your 50-year mark, doing all of the above. So you want aerobic, but you also want strength training. And in some cases, targeting on balance training might be necessary and prudent. But if you're doing all these other things preemptively with cardiovascular and targeted strength training under appropriate guidance from a professional who knows what he or she is doing, you're doing a lot towards preventing a really intensive need for focused balance training, because all of that is going to be worked in with everything else. If you hit the literature, you will see that there is a significant link between regular performance of Tai Chi and decreased falls, because it does help with the neuromuscular connections and maintaining balance for older adults. So that is something that we know can help to modify, especially for people who are in their later decades. And that goes a bit beyond the 50-year mark that we're focusing. So in order to answer the question, I felt like I kind of had to start even earlier and then go later. But definitely around the 50-year mark, cardiovascular conditioning as well as making sure that you are not neglecting that strength training and not just doing it on your own, but relying on advice and observation, at least initially, from a trained professional is very important. As far as eating right, diet.
Can I dive into the exercise piece too a little bit, Rob?
Please.
So I really, I'm a huge proponent of the yearly physical with a PT, a physical therapist. And especially, I think if you're healthy in 30, you probably don't need it. But right around 45, 50, that things start to kind of break down a little bit. The blood flow to the rotator cuff changes, the blood flow to the proximal musculature changes. I think the yearly physical is huge, just to break down, hey, these are your strengths and weaknesses. What a physical therapist does is they literally assess range of motion and muscle strength.
Yes.
So we could break down specifically where you're weak, and it might just be 3 to 5 exercises that you do throughout the course of 2 to 3 days a week, and you're preventing that rotator cuff tear that 60% of people have after the age of 50, right? So little things like that, and then just quad strengthening, watching it. There's just such a myriad of different ways to do a squat, but factoring in, if the person has bad knees or condylar patella, or they've been a runner, or their activity tolerance in the past. It's just, there are so many factors that go into an exercise program that's, I think, to your point, I think it's really important that, a PT have a look, a good, certified PT who's, functional movement, SFMA maybe certified, can really look and break down the motion, and I would say that would start at age 45 or 50, and just like look at everything, see what's going on, and prescribe. And you're right, maybe 1 or 2 visits, especially if there's no pain. They do their exercises, check in with you maybe in 3 to 4 months and say, hey, Sean, this program's going great. Hey, Sean, this program, I'm still having some shoulder pain. What can I do to fix that? Huge. And then the balance piece too, just to touch on that. And this, again, that like the whole exercise thing could probably be an entire webinar too. But the balance, a big question that I get, especially for my older patients, is, can balance be improved, right? And I think you need to speak to the 3 different systems, which is vestibular, it's vision, and then it's somatosensory, or what you get from your feet or your hands, right? So a lot of times we'll see people with BPPV, and I'm sure you get that a lot too, and that can lead to a fall, that can lead to an injurious fall, and that's just as simple as doing a really easy maneuver. So just different things, and maybe we can touch on the BPPV thing. And it's not always that simple. It's not always just a positional vertigo, but that can cause a fall too. And the point of this webinar, really, from an orthopedic sense, is we want to prevent falls, number one, because that can lead to hip fractures and other things, hit your head, things like that can increase your risk for mortality. That's a huge thing.
And I'm glad that you mentioned BPPV, because I know that one of the other points that we want to touch on at some point today was medications to try to avoid. And oftentimes people will go in with dizziness either to the emergency room, urgent care, or primary care, and they'll get prescribed a anti-vertigo medicine like meclizine, which can help a little bit in the short term. But if that's all that somebody is doing in order to try to help themselves, it can actually be detrimental. It can create a dependence on the medication. You withdraw the medication, the vertigo actually gets worse, and they get side effects from the medication and fall because of that. Whereas if it is benign paroxysmal positional vertigo, then that can be fixed non-pharmacologically by physical therapy maneuvers, namely the Epley maneuver, in order to reorient to little calcium stones that have built up with age in the vestibular organ. And in the labyrinth there, and resolve essentially the vertigo. And might there still be episodes that require repeat maneuvers and assessments? Yes, but it avoids great discomfort, deconditioning, because people can't do what they would normally do, and it avoids the unnecessary use of medications. So I'm really glad that you mentioned that.
And can you touch on just the different types of dizziness too that folks can, they present to your office with?
Yeah. So oftentimes it ends up first sorting out semantics. So people will say they're dizzy. Oftentimes when I ask, well, is the room spinning around you, or do you feel like you are spinning? The answer is no. And the ultimate verdict is that it's not true dizziness, it's lightheadedness, at which point we're looking at hydration status, we're looking at blood pressure swings, we're looking at other underlying neurologic disorders such as Parkinson's, which can cause blood pressure swings, and ways to modify those kinds of things rather than focusing on what one thinks is dizziness. But as far as, if it is vertiginous, is the dizziness vertiginous? Do you feel like there's that actual spinning sensation that you can see and feel? Then you are looking at either peripheral or central vertigo. Peripheral, like you said, being the inner ear, central being, oftentimes because of something like a stroke, unfortunately, that has left some of the brain tissue damage that would normally allow somebody to perceive their world and balance well. It definitely has a bearing on initial assessment and treatment, as well as prevention if we're looking at cerebral vascular disease. Whereas if you have peripheral vertigo in the inner ear, then referring somebody to a trained physical therapist to do those kinds of maneuvers is the best treatment.
Yeah, that's great. So let's talk about. So we were talking about stroke and and central causes. Let's talk about nutrition. Let's dial it back and talk about ways to potentially hopefully prevent stroke. For that 50-year-old, 60-year-old. Let's talk about that. How should they change their habits? What are some small things people can change? I think we should talk about the ideal diet, and then maybe just dive into some small, like turning the dial changes that people can make if they don't want to, completely overhaul their entire diet.
Yeah. So the one broad thing that I was going to say about eating right, so to speak, is what a lot of dietitians will say, which is eat the rainbow. If you think about trying to eat a wide variety, of course, fruits and vegetables and whole grains, everybody on this call is probably aware that those kinds of foods are better than the processed sweets, high fat foods, especially high saturated fat foods, things containing not oils, but more along the lines of butters and creams. Those are some high-level guiding factors in trying to achieve a better diet. But as long as you have that in mind, then proceeding forward, what are the next steps in trying to think properly about diet, and that idea of eating the rainbow. So if you have your 3 favorite fruits and 3 favorite vegetables, that's good. But if all of the fruits are orange and all of the vegetables are let's say green, while that's good, if that's the only thing that you're eating, then you're likely to get into vitamin deficits. You're not going to be getting complete plant proteins when you're trying to make plants and not red meat, for example, as more of a primary protein source. So if you're looking at vegetables, just to dial in even further, and you can bring yourself to eat green beans one night, beets the next night, cauliflower the night after that, broccoli the night after that, and so forth, then you're going to be in a lot better position nutritionally than you otherwise would be if you have too narrow of a focus on just a couple of fruits and vegetables. So that's one guiding factor. And as I alluded to, trying to get any animal proteins from more lean proteins such as poultry and fish, then you'll be in a lot better position. And particularly, a lot of forms of fatty fish will have those good omega-3 fatty acids in there that are good for neurologic function. So, those are some of the things that immediately jump to mind that people can and should be thinking about in terms of the broad overview of the diet.
And what are your feelings on a multivitamin?
Glad you asked. I had that down here. I wanted to make sure that I addressed that. So one of my favorite sayings is that by and large, a multivitamin will usually only serve to make expensive urine. a lot of these vitamins have too much in terms of daily value of each of these elements, and the elements are often not absorbed nearly as well as they could be, as if they were being gotten from a food source. So rather than saying, oh, I'm taking a multivitamin, so I'm okay, that really doesn't hold water. It's really making sure that you are getting natural vitamins from your food sources, really using that food as medicine in order to get your daily value of everything. And does that mean that you need to be tracking, okay, well, that broccoli had so much folate, so I'm good there. And, that's exhausting. It's completely time consuming and not attainable for most people. So if you know that you are rotating the color of your fruits and vegetables and eating a lot of servings of each day, and not overindulging in more concentrated sweets and red meat and everything, then you'll put yourself in a pretty good position. And to give a specific example of how a supplement is not always going to be nearly as helpful as a food source, vitamin D. So about a decade ago, vitamin D became huge, and I think it's still very important, especially where we are, Sean, in the Northeast, where I'd say most of the population probably is vitamin D deficient unless they've done something about it because of the lack of sunlight around the year. If somebody takes a vitamin D supplement, but they take it at 6 in the morning and they don't eat anything until 9 o'clock, a lot of that vitamin D is going to go straight through because it's a fat soluble vitamin. It needs to, this is an instance where, your body needs fat. We know that our bodies need fat. So you don't want to be on a fat-free diet. You're not going to absorb most of that vitamin D. So vitamins A, D, E, and K are fat soluble. They need some fat to be absorbed in the intestine. And, so that's why, in some circumstances, whole milk may not be such a bad thing because it contains vitamin D, it contains calcium, and it's got some fat in it. And as long as you're not drinking a gallon of it each day, then you're not going to get too much lactose, and you're not going to get too much saturated fat in your diet. So that's one specific example of where supplements just are not going to cut it.
It's really interesting. So the supplements, it's so tough, right? Because, and to your exact point, I mean, you need sunlight to synthesize vitamin D, right? So,
right.
And then, do you take your supplement with a glass of milk in the morning, is it a whole fat milk, that sort of thing? Like, I guess that's what you're saying, maybe you'd recommend, right? Like just a glass of whole milk with the multivitamin to get the most out of it,
Yeah.
But I think that's a really interesting point. I think, we try to do our best to eat the rainbow. Nobody's perfect, and I think that's where, and it's so tough. I wish there was a scenario where, and I think some private nutritionists do this in the Boston area, but they'll take blood and then they'll tell you your exact nutritional profile and where you're at with every single vitamin. And really our medical system doesn't do that. It just tells us where, H&H is and, all the, the other, maybe, and I don't even know if I'd call them more important or less important. It's just, the typical panels that we run don't qualify what our nutrition actually, as a lagging indicator, won't tell us what our nutrition is like, and that's too bad. I wish that would help hugely in a preventative piece to use your words. I mean, nutrition is, that's a medicine, your food is medicine. So if we can use it properly and have the right consultation, that's, that could really change some lives.
Yeah, absolutely agree.
What's the next thing you're gonna jump on there?
Well, I also mentioned avoiding toxic habits and staying socially engaged. So
yeah, let's talk about that.
Yeah, so toxic habits, a lot of people are well aware, any kind of substance misuse, abuse is going to be detrimental, both in the short term, in a lot of cases, as well as long term. So avoidance of overindulging in alcohol, tobacco, other drugs, even ones that have been recently legalized, can be detrimental in the long run. And I'm not sure if there's really too much more to say or take time about that, other than specifically focusing on alcohol for a moment. Alcohol is kind of like eggs, in terms of, oh, some of it is good, oh no, it's all bad, and this kind of pendulum saying eggs are good, eggs are bad for you, eggs are good for you, eggs are bad for you. Same with alcohol. There was one point where 2 drinks per day was okay, and then there's some cancer studies saying, oh, maybe really just scale it back to 1 because of the cancer risk. But then there's the other end of this side of the table, where a glass of red wine per day probably does help some with cardiovascular disease risk, and that is a real thing. So, the best thing to say, I think, for a lot of these kinds of things is truly moderation, and avoidance of binge drinking, I think, is very important. Because even if you only have 7 drinks of alcohol, standard drinks of alcohol per week, if you're having them all at one time, then that can be very toxic. So moderation, and truly adhering to the letter of the law in terms of what's considered to be safe at any given time, with the best knowledge that we have. So that's what really all that I have to say about that. And then staying socially engaged. One of the things that I would always advise people as they get older is, what's your support structure? Is it family? Is it friends? Is your geographic location the best in terms of considering where you're living now versus where maybe you should be in the decades to come? It's really important to be near a support structure that you can lean on, so to speak, and not necessarily 24/7, not to the point where you would necessarily feel uncomfortable in asking people for help, but just assuming that it's family that you're talking about, moving closer to family as you enter into the later decades of life, not necessarily because you need help now, but because you might need help later on, and then not being afraid to ask for that help when you truly need it. A lot of people are afraid of being a burden to their families, and my response to that is, a lot of families don't feel that way, and they want to help the older members of their family. And the other part of it is, if you ask for help earlier on, when it might not be as readily recognizable by other members of your family that you need help, then you very well might be able to avoid more severe or even catastrophic events that end up truly placing even more burden than otherwise would have been occurring on your family. So, it's very natural to want to avoid that, and to not need to be cared for in any way and be independent. And that should be encouraged. But a way to encourage that, actually a little bit counterintuitively, is to engage in your support structure earlier on, before things get worse. And oftentimes things can be helped either back to prior baseline, or at least closer, such that bigger burdens don't happen overall to everybody later on. And the other piece of staying engaged with your support structure is just really for overall mental and physical health. We've seen a huge amount of decline, especially in older adults, in their mental status, and depression and anxiety over the pandemic, because of just the inability to engage. And yes, it's good that we have modalities like this, like Zoom, where we can reach out and engage, but it's in a lot of cases, it just hasn't been enough. And even people who did not get COVID themselves, did not start out with any kind of dementia, really took a huge dive in terms of function, ability to care for themselves, unintentional weight loss, depression, and they don't look like the same people as back in 2019, not because of any other event besides just being socially isolated. So very, very important.
It's incredible, and I think, the toll that the pandemic has taken, not only on mental health, but on memory, and just, I'm sure the memory units, and just we take for granted just the social interactions that you have and how that can challenge your brain, right? Because you have to respond, you have to think maybe outside of the box a little bit when you're having a normal social interaction. And that was lost during COVID, and it really probably especially affected 70, 80 plus population.
Yeah.
They're not seeing their kids every day saying, how's it my grandchild or this or that. It's much more, it's less, I call it brain work, right? You're just not using the same, you're not using your brain. And if we look at the brain as a muscle and you're not challenging it, it's going to atrophy. And another piece that I think we should touch on just with that is falls, right? So how often, with a weaker support structure, or just weaker communication with our aging loved ones, will they just not report a fall? You'll notice they'll have a little scuff. I think some of the telltale signs are either a mark on the face or a mark on the arms, hands, that sort of thing, on the legs. And just I think as a concerned loved one, it's fair to ask, hey, mom or dad, or grandma, grandpa, is everything all right? What's what happened? And if you start to see a pattern, that's something we just want to address. And I think that starts at the primary care level or the geriatrician level, and say, hey, listen, you just have to bring this up. And the fear of getting sent to a nursing home or an assisted living is you will be there if you don't have the conversation today. And that's what needs to happen, because if we can prevent it, which you can just by strengthening some muscles, most 90% of the time, we can strengthen up a little bit and address the balance and change it, then you won't end up in a skilled nursing facility for 90 days and then discharged home with, a full-time home health aide. We just don't want that scenario. So just the transparency is huge there.
Yes. Yeah. No, absolutely agree. And earlier is better in terms of intervention. And if you miss that opportunity, sometimes there's no going back.
Right. It's tough. We all know the stats with the hip fracture of, you fracture a hip, there's a very high mortality rate within a year. We're avoiding
about a third. Yeah.
Yeah. So 33% of people pass away within a year after a hip fracture. So those aren't great statistics. So we try to avoid them, and PT is a huge part of that, but it's the same thing with you, Rob. Noticing balance issues, doing a Romberg test, closing checking everything is huge. Let's talk about, we're kind of coming up on the hour here, but let's just talk about polypharmacy. Let's talk about prescriptions. Which ones do you tend to stay away from? Which ones, are your go-tos, I guess, for different conditions? Would love for you to touch on that.
Yeah, absolutely. So I'll tell you about what I try to avoid and go from there. So anything that is going to be sedating, mind altering, sensation altering, I try to avoid. So one of the first places we go, of course, is opioid medications, but even other medications like bladder antispasmodics that might help to prevent overactive bladder or urinary incontinence, which are good. Maybe sometimes some bladder retraining, some pelvic floor muscle strengthening could avoid and obviate the need for additional medications. And it's just taking that one further step of what else besides pills can we throw at this thing, whatever the problem is. So that's one thing that we should always keep coming back to, is what else is there in medicine besides medicine to help to address an issue. So anything that is sedating or sensation altering at all. Even those that are not, like NSAIDs, non-steroidal anti-inflammatory drugs, ibuprofen, naproxen, Motrin, Aleve, all of these can be very good in some circumstances, especially short-term in the right individuals. However, they can be dangerous and lead to complications, hospitalizations, and even death in some other individuals, especially those at increased risk for bleeding, particularly gastrointestinal bleeding. Think about stomach ulcers, ulcers. And those with cardiovascular disease, the way that NSAIDs work is that they constrict the arteries, thereby decreasing inflammation. And if one of your problems is artery narrowing at baseline, then you have to be really careful about that. So by and large, people with cardiovascular disease, I avoid NSAID medications in, or if it's really going to be likely to help in a very discrete time period. And, I know that their cardiovascular disease is stable. Sometimes I will put somebody on 1 week of naproxen and just limit it to that. And I pick naproxen because it has been shown to have just a little bit less cardiovascular risk associated. So I limit the course in those cases. And if it's a patient who doesn't have cardiovascular disease, I always accompany an NSAID medication with a stomach protector, either a proton pump inhibitor like omeprazole, Prilosec, if they're going to need to be on it for a longer term. Emphasis on need. We really want to define how frequently, how much, and for how long you need any medication, and then cut it off or taper it off after that if it's safe and effective to do so. And then the other thing that I will use in conjunction with an as needed NSAID medication, I take ibuprofen every so often for my knee because it acts up twice per month and it really helps me. I'll say, okay, take some Pepcid, famotidine over the counter whenever you take an ibuprofen, and that'll protect your stomach. Take it with food. That'll protect your stomach. You don't have any underlying cardiovascular disease. The use of the NSAID is limited. And fine, you probably have a good risk to benefit ratio in using a medication that way, because it's actually promoting function. And what's the bigger risk in that scenario? A decline in function because of pain. So you always have to talk with your doctor and weigh risks and benefits of absolutely every intervention. One other class. Oh, go ahead. Yeah.
We'll just pause there. So the NSAIDs, obviously, I don't prescribe them personally, but I highly recommend them in a lot of cases. And it's funny because I've never really thought about the vasoconstriction component of it. I just think of the acute inflammatory component and trying to control that for a tendinitis or some sort of inflammatory.
Yeah, it's great for that. Yeah.
But my question to you is, at what age do patients need to start worrying about like a stomach bleed or an ulcer there?
After age 60, it starts to rise. The curve of incidence starts to rise pretty intensely. Of course, before that age, anybody can unfortunately have a bad family history of coronary artery disease and be predisposed themselves, or have had an early heart attack at age 45. So, so for all comers in general above age 60, become more careful, but always consider your own past medical history and family history.
Good. Great.
Yeah. One other class of medications that I do want to mention, and that goes a little bit, I think, outside the scope of this talk, but is really important when you're talking about polypharmacy in older adults, is laxatives. A ton of people, as they get older, start to have difficulties with constipation. There are a lot of over-the-counter medications that are available as well as prescribed. And one take-home point in terms of medications from that perspective that I want everybody to know is to try to avoid stimulant laxatives, or at least very regular use of stimulant laxatives. Primarily things like senna, which can work great to clean somebody out, but can definitely cause colonic inertia, inability to pass stool without taking the medication. You really develop a physiologic dependence on stimulant laxatives. So trying to stay well hydrated is first and foremost if you're having constipation issues, and adding a warm cup of prune juice at night can really help as well. And if you really need something extra, an osmotic laxative that pulls water into the stool and makes it easier to go, rather than really being heavy stimulant can really help. And then using that as infrequently as possible in order to achieve the desired effect. And this being things like Miralax, polyethylene glycol. So that's the one other medication point that I wanted to make.
Yeah. And so what are you seeing as sequela to constipation?
So counterintuitively, diarrhea. If somebody doesn't address their constipation, then they can develop heavy stool impaction, around which liquid stool will start to leak. And I think while I'm having fecal incontinence of all of this liquid stool, I shouldn't be taking a laxative. But that really gets into sometimes a dire situation, because that's an impending bowel obstruction, even though somebody is having a problem with liquid fecal incontinence.
So talk to your geriatrician if you're having constipation.
Yeah.
And make sure that and Miralax is what you'd recommend, and that pulls
Yeah.
water into the stool.
Yeah. But hydration first, prune juice probably second. Might have some implications if you're a diabetic, because there's a lot of sugar in that. And then if you really need to move to some kind of traditional medication, Miralax.
It's interesting too, Rob, because we get a lot of low back pain, and we do have a women's health specialist on staff here. That is triggered by constipation. Low back pain and sciatic and things like that. That there is a layer to the onion there that may have been constipation, right? And we're treating orthopedically something that is in a totally different system of healthcare.
Right.
That's really interesting. So yeah, I mean, this has been great. I mean, super informative, Rob. Anything else that you wanted to touch on before we sign off here?
Yeah, I think we covered a lot of ground. Thank you very, very much for having me. It's been great talking to you, and I hope that everybody on the call has gleaned something useful for themselves, for family members, hopefully for both. And in terms of any parting words, I would say, really, I think the most effective thing that I can do is to echo something that you said earlier, which is, even if at the point where you are in your life, you're feeling good, you're functioning well, you can play your golf and not feel like you're getting injured right now. You can go on walks with your dogs. You can play with your grandkids on the beach, and it doesn't seem like a problem. It's a really good idea to not just go for a physical with your doctor, but to go for a physical with your doctor of physical therapy as well, and identify those areas that are weak and might not be bubbling to the surface until a decade later. And you could really do something very positive about it now, because that's going to prevent decline, not just physically, emotionally, but medically. I really appreciate and advocate for that point.
Love that. A little public service announcement from Dr. Rob. Well, this has been great. Really appreciate you having you on, and thanks for your time.
Yeah, thank you for having me. I really enjoyed it.
My pleasure. All right, Rob. Thanks so much. You have a great day.
You too. Be well, everybody.